Now I just want to finish up with saying a couple of specifics about some first and some second generation antipsychotics. So I'm going to start with the first generation. I still think you should just remember haloperidol because it's the most often used. But there are many more, things like trifluoperacin, fluphenacin, chlorpromazine, thioridazine. There's a lot of times this acin ending which can be helpful to recognize a first generation antipsychotics. Now, sometimes people may talk about so-called high versus low potency drugs. And it turns out that these three are what we call high potency drugs. What does it mean? Well, if a drug is high potency, means you need very little of the drug to get a certain effect. In contrast, when you have a low potency drugs, you need quite a lot to get a certain effect. Now, if you're thinking about it, that means that if we use one of these drugs, also haloperidol, well, to get a certain effect, we need very little of the drugs, and it's directly related to how much do we need to block dopamine receptors. Well, we said all this, particularly the first generation, have this ham adverse effects. So you can imagine if you use these high potency drugs, we're going to have just a little bit of H1 muscarinic and alpha-1 blockade because we need much less of the drug. In contrast to the low potency drugs, we may have much higher effects on these receptors, the extent of blockade, H1, M, and alpha-1, because we need to use a much higher dose to get our specific dopamine blockade. Now, what has this as a consequence? Why is that clinically relevant? Well, if you look at these receptors, we're going to have here the muscarinic receptor. Now, you're thinking, well, I don't want to have dry mouth, constipation, blurred vision, urinary retention. Obviously not. But this is also very helpful for EPS because we said the EPS are due to the disbalance of dopamine and acetylcholine in the nigrostriatal pathway. Now we block dopamine and we have too much acetylcholine. Now we get all this EPS effect. But how can we treat it? Well, with anti-muscarinics. So to treat the adverse effect, we give anti-muscarinics. Now we have this already here. That means those guys, the low potency drugs, have actually a lower incidence of EPS. And I hope that makes sense because you basically give already the treatment with the drug. Whereas for the high potency drugs, because they're so high potent, we don't need use a lot high dose. We have only a little bit of muscarinic effect, and therefore we're going to have a high chance to develop EPS. And sometimes if a patient gets EPS, well, an option may be also to switch to a low potency drug.